Good afternoon, everyone. So I'm not going to use the PowerPoint, but I do have my notes in front of me. It is always kind of fun to talk after lunch, after we've gorged ourselves about health. I am going to be very brief, and my topic is to talk about health directions as we approach the next new wave of health policy and health research. And as I think about the notions of directions, I feel like there are three guiding questions that has to do with directions. Where are we? Where are we going? And in some cases, thinking about Ice Cube, are we there yet? And so my talk is really framed in that mind space. So where are we? So in America, it goes without saying that health and healthcare costs. And it is apropos that we'd be at an economic summit talking about health, especially given the economic challenges for families and for communities that health pose. And I'm sure it is clear to everyone that Black and brown communities and impoverished communities are those who are carrying the heavy economic burden as it relates to health challenges. So this is where we are. So we have about 15 million Americans 15% of Americans living in poverty. That's roughly about 42.6 million people. And many of those people, over 10%, are the working poor. Blacks and Hispanics, right, I rather say Latino, are much more likely to fall into this category, and certainly women are heading this list, particularly mothers. Now, the rates of poverty for children are particularly high, especially for those who are under 18. Almost a fifth of children under 18 are living in poverty, and adults 18 through 64, there's about 14% of them that are poor. And of those who are poor, more than a quarter of single mothers are without health insurance, compared to over 90% of the insured mothers in married couples. So we can imagine that America's most mortal family type is a single mother with children being uninsured and living in poverty, what that means for your health. Right? So about 16.3% of Americans, roughly about 50 million, are without health insurance, at least in 2010. And we now have the passing of an act that's intended to adjust to this. Now, for Black mothers, about 10 million single moms in the United States, and 13% of the country is Black, and the substantial number of single mothers really are Black mothers. So what does this mean? What does poverty have to do with health? What does health and poverty have to do with economics? Well, we know that if you are poor and are in need of health insurance, you will be using several state programs like Medicaid. And Medicaid and CHIP provide care for about 40 million children a year. Children's access to dental care has increased, but not through this program. So I'm going to talk with you in a few minutes about Title IV of the Patient Protection and the Affordable Care Act, and what does that mean for us who may be interested in where do we go from here and where are we going. So the passing of the legislation means a lot of different things, and I'm sure that it's contested, and we're going to hear from one of our discussants about that. But particularly Title IV should be of interest to us. Title IV in the Act is called the Prevention of Chronic Disease and Improving Public Health. And in Title IV, we begin to see that the population of people that we really care about, right, which is not to say that we don't care about people who are not poor, but those who really garner and need most of our attention, those who are Black, brown, poor, uninsured, this is where the action will be for them in this Title IV. So Title IV states that not later than March 23rd in 2011, the chairperson, in consultation with this council, must develop and make a public national prevention, health promotion, and public health strategy, and review and revise such strategy periodically. And it should target these areas of nutrition, exercise, smoking cessation, and the 5 leading disease killers. So in the United States, the top 5 leading killers are heart disease, cancer, chronic lower respiratory disease, stroke, and accidents. That's for all of the United States. For Blacks, it is heart disease. They share number 1. Number 2 is cancer. Number 3 is different, stroke. Number 4, diabetes for Blacks, which is number 7 for all of the US, and unintentional injuries, right? Now, unintentional injuries is a funny category. I can hear Sandy Darity saying, I didn't mean to shoot you. It was unintentional. So driving while black might be in that category, but to our particular focus. So we have in these 5 leading causes chronic illnesses that are preventable and are structured. And so we begin to say, what will happen? Where will we go from here in terms of the Patient Protection and Affordable Care Act? And what it clearly says is that given the charge of the council, we will be going to look at what actions need to take place in order to prevent these 5 leading deaths. And we need to pay great attention to nutrition. Who had the fried chicken? Exercise. Who worked out this morning? That's a dramatically lower number. And stress. And we know now from the research around racial stress and allostatic load what this means for our society. So the question is, will there in fact be some action? And what and where do we go from here? So here are some of the things that I think that are important for us to think about. The largest concentration of blacks are in the South, right? 55%. We also have really large black populations in Mississippi, Louisiana, Georgia, Maryland, South Carolina, and Alabama. The leading cause of death in most of those places are related to things that are preventable, right? That the structural environment allows to occur. Right? So as we think about the direction of the Patient and Affordable Care Act, we begin to think, if we have to put our money on a particular set of action that would make it preventable, where should we put our money? Now, I run the Grassroots Community Foundation, and this community organization's target is 10 cities where women and girls have the worst health outcomes. And we provide funding for community health programs and community health organizations such that they can do the work. And we provide them with technical assistance and support. My partner is Black Thought. You might know him from the band The Roots and the Jimmy Fallon Show. And what we have recognized is that in cities and in states like Mississippi, Louisiana, Georgia, Maryland, South Carolina, and Alabama, is that those at the lowest levels, the towns, the counties, don't often have the attention of these kind of broader rubric. I heard one speaker say today that we have to think, right, what is going to be the mass effect? But before one gets to the mass effect, one must think about the local micro processes, right, that are occurring in cities and towns that become the waves. So that tells us that 1, we know where we are. 2, the question, where do we want to go? It is not clear that we want to create a society where everyone is healthy. It is not clear that there is great benefit in that for the majority of people. But for some of us, particularly those of us who are at this meeting, it is most likely that we are interested in better health and well-being for these communities. What I suggest today is that as we look at preventable health, we begin to include something that is often missing. That we do have, slated in the bill, exercise, prevention, we do have diet, education, smoke cessation, et cetera. But one thing that is keenly missing is oral health. Nowhere in the policy there is one provision that begins to talk about it. Is there a significant amount of attention paid to oral health? Now, oral health is related to many of those cardiovascular diseases, particularly to heart disease, and the evidence says that that's growing. First, it was a nation evidence that suggested this relationship, but it is now growing to show that oral health. Now, we know that in our society, we know from some of the early research that oral health also affects whether or not you're going to be employed, much like obesity. That those who are overweight or obese are less likely to be hired if there is a job interview. Kids are not likely to be admitted to school if there's a face-to-face interview. We make assumptions about people, their competency, their intellect, if they're overweight or obese, right? Similarly, oral health presents that problem. Now we have the covariates of oral health and heart disease. So in our communities that are largely communities of women and children, the provisions that have been laid out ignore, except in the aspects of insurance. So the insurance information does talk about including oral health, but it is not broadly stated in the terms about preventative care. So as we think and we begin to focus on things, people like to think about obesity a lot. Our work thinks about obesity mostly because of the cosmology of it. We can see, right, that people are big. We make assumptions that bigness means unhealthy, right? We've come to, at least, hopefully, to understand that those are not necessarily truths. However, we can see teeth. But beyond teeth, we know that decay will live. And that decay is not just aesthetics, right? Whether or not you get the job or not get the job. It is also about the well-being of the person. But even if we were going to be, right, singularly focus on the aesthetics, if you are unemployed, if you did not get the job, right, then you now have a new levels of stressors. Those stressors translate to poor health. Those stressors translate to unemployment. Those stressors may translate to child abuse because of the stress. Anybody who has a kid knows, really? It's going to be challenging to talk to you when I just did not get the job, right? And we know that our communities are hyper-surveilled, not only by police, but also by child welfare. So we begin to think beyond what the policy has stated. So let me ask, at least with the final few minutes, to say, I've told you kind of where we are. We're poor, we're uninsured, we're mothers with children. Where we want to go is unclear. And so it's difficult to ask, are we there yet? But it is clear that even with this new law and this new policy, if we were to resurrect the ice cube question, are we there yet? The answer is clearly no. We are not there yet, because even in the policy, particularly section 4103, that talks about Medicare coverage of annual wellness visits, we still don't have a lot of attention to the key issues that are going to affect our health. So we're not there, but I think it's important for us to remember that we still have the possibility of sharing the driver's seat, that we can still begin to enact policies both at the local level and the national level that can get us in a new direction. Thank you.